Morning everyone. Welcome to the clinical meeting. Dr. Tambu sir had sent a message that everybody's presentation should be under 8 minutes. So we'll start the clinical meeting. Okay, we'll start.
Good morning, everyone. I'd like to present on my topic, the white child. Presenting a 32-year-old female presented with the complaints present to the OPD for routine diabetic evaluation. During that time, she had complaints of some mild pain in the upper back. This for 1 month. It's a dull aching type of pain, not as with the early morning sickness. She did not complain of any radiating pain. No history of difficulty in lifting the hand above the head. No history of difficulty in holding the pen. No history of tremors, paresthesia of the upper limbs. No history of bladder and bowel incontinence. Past history wise, she's a known diabetic for the past 4 years with an index sugar of 400 milligrams per deciliter. She was detected during the evaluation of a treatment of infertility. During that time, she was initially started on OHA. However, following which, after which she had become pregnant, she had required insulin. Following which, she was continued on a combination therapy of metformin and glimepiride. Family history wise, her father and uncle are known to be a diabetic. Onset of diabetes is still unknown. So examination, when she had initially presented, was conscious oriented to time, place, and person. No tendon xanthoma, no xanthelasma, no corneal arcus. The height was 158 centimeters, the weight being 66 kgs, and the BMI of 26.4 kilograms per meter square. On examination, she was vitally stable. There was no pallor, victus cyanosis, clubbing lymphadenopathy or edema, no elevated JVP. Systemic examinations, the CVS and the RS were normal. The abdomen had shown she was found to have a liver palpable 5 centimeters below the costal margin. Otherwise, there was no splenomegaly. Examination of the CNS, most of the CNS examination were normal. However, the fundus had shown a typical creamy and whitey layer in the blood vessels. Can anyone from the audience name what it could be? So this is lipemia retinalis. Basically, it's characterized by a whitey blood which is in the blood vessels characterized in the retina. So summarizing, a 32-year-old female with a young onset diabetes mellitus with future suggestive along with future suggestive of lipemia retinalis. Investigation. When she had initially presented, she was found to have a hemoglobin of 10 with a WBC of 9,600. Platelets were normal. LFT, which was done, could not be processed in view of the hyperlipidemia. AC was 207. The postprandial sugars were 296. Urine routine had shown a glucose of 4 plus with blood of 2 plus, and the electrolytes had shown a pseudo hyponatremia of 104 with a potassium of 3.2 and the bicarb of 8. Urea was 16 and creat was 0.84. ECG and chest X-ray were within normal limits. So her TSH was normal. The ultrasound we had done was also normal, which had shown hepatomegaly. So coming to the lipid profile, her lipid profile had shown a triglycerides of which was massive triglycerides of 15,780 with a total cholesterol of 1,600 with a LDL of 271. So now I'll like to elaborate on the burden of hypertriglyceridemia in India and the management of such severe hypertriglyceridemia and the need for it to be managed on an emergent basis. So hypertriglyceridemia in adults, the burden, the management of severe hypertriglyceridemia. So this was a study done in by ICMR, which shows the prevalence of the dyslipidemia in urban and rural population. It was done in 3 states: Tamil Nadu, Maharashtra, and Jharkhand. There were 16,000 members were taken for evaluation, and every 5th member they had taken lipid sample for evaluation. It was found this test has found to have showed that 79% of the 2,000 population, which is astonishingly high rates of dyslipidemia in Indian population. Indian population, and there was only 21% of the people who did not have lipid abnormalities, and there was 30% of the people having triglyceridemia with a low LDL of 70% of people and a hypercholesteremia of 13% of the people. So, and there was also a regional disparity which could be seen in hypercholesteremia. Tamil Nadu being the highest, showing 18% of the people among Tamil Nadu were found to have hypertriglyceridemia, with the highest LDL of been found in Tamil Nadu of 15%. With the highest rates of low HDLC was found in Jharkhand, which was almost about 80%. However, the incidence of familial hypercholesteremia in India, there was a study done which had taken 4,000 population, among which 4 had satisfied the criteria of familial hypercholesteremia, indicating a prevalence of 1 in 1,000. Out of the 90 patients which are enrolled, only 14 patients were found to have 4 patients were found to have definite hypertriglyceridemia, with 14 being probable and 13 being possible, and 39 being unlikely. So there are many criteria for classifying familial hypercholesterolemia. The main criteria I want to emphasize on is AHA criteria, which shows LDL more than 190 milligram per deciliter, with the first degree relative having a LDL more than 190 milligram per deciliter, or a person who had a premature coronary artery disease in men which was less than 55 years of age, or in women which is less than 60 years of age. This is another elaborate classification, Dutch criteria for familial hypercholesterolemia, which includes the family history, clinical examination, biochemistry, and molecular genetic parameters, and a scoring system which classifies them based as a definite, probable, possible, and unlikely to have a familial hypercholesterolemia. So, mechanism of this hypertriglyceridemia. So basically, there are two apolipoproteins, namely VLDL and chylomicron. VLDL carries the triglycerides from the liver, and chylomicron carries the triglyceride from the intestine. Both of which are responsible for carrying the triglycerides. And the lipoprotein lipase, which is found in the adipose tissue muscle, are responsible for lipolysis of this chylomicron, thereby liberating the triglycerides in the circulation. So basically, insulin inhibits this lipoprotein lipase, thereby preventing the triglycerides from entering into the circulation. Why there is need for this apolipoproteins is because when the apolipoproteins are combined with the triglycerides, then only it can be eliminated from the body. If it's not eliminated from the body, it gets accumulated in the form of triglycerides in the blood. So I like to emphasize on the classification of lipid disorders. There are 5 classifications of lipid disorders. The first one would be increase in triglycerides due to high chylomicrons, and the Fredrickson type 2 would be increase in LDL, and A would be increase in only LDL, and B would be increase in both LDL and VLDL. Our patient had both increase in triglycerides along with total cholesterol, which indicates our patient to be in type 2 Fredrickson class. And there are also type 3, type 4, and type 5 Fredrickson lipid classification. Type 3 being increase in both VLDL and chylomicrons, remnants of VLDL and chylomicrons, and type 4 being increase in VLDL, and type 5 being increase in chylomicrons and VLDL. So the secondary causes of hypertriglyceridemia could be medical conditions like obesity, uncontrolled diabetes mellitus, hypothyroidism, Cushing syndrome, and the drugs which are most common drugs we need to consider were thiazide, beta blockers, atypical antipsychotics, which are most likely to develop, and severe elevation is seen most commonly with the protease inhibitors, which are used in HIV. So why there is a need for treatment of severe hypertriglyceridemia? There is an article published in Clinical Gastroenterology which had shown that if the triglycerides are more than 1,000, there is a 10% increase of acute pancreatitis, and if the triglycerides are more than 2,000, there are 20% increase in acute pancreatitis, and as the triglyceride goes down to more than 5,000, there is a chance of 50% of acute pancreatitis in this patients. So I will only emphasizing the management of severe hypertriglyceridemia. So the management, it can be classified mainly into two types: the patient who had a hypertriglyceridemia leading to acute pancreatitis, and the patients who are at the risk of developing, who hasn't had developed pancreatitis till later. So the patient, as that triglycerides grow on, there is an increased chance of developing pancreatitis. There are only two methodologies can be used: insulin infusion and total plasma. Uh, Therapeutic plasma has shown to have a 60% reduction in triglycerides compared to the rest of the population, and insulin infusion, which we commonly use, has shown to have a rapid reduction in triglycerides, which we use 0.1 to 0.2 units per kg per hour. So the management of severe hyperglycemia in patients who are not developed pancreatitis would be: weight loss would be the first thing. Dietary changes are the most second, but to have a reduction in hypertriglyceridemia. Contrary to the belief we have, usually we think that most drugs like fibrates have more efficacy in reducing hypertriglyceridemia. However, the meta-analysis of 7 studies, including fibrates, have shown that it does not reduce the incidence of pancreatitis with person who had used fibrates. However, the same study also had shown that using statins have shown to have improvement in reduce the risk of development of acute pancreatitis compared to fibrates. Omega-3 fatty acids also have theoretically shown to reduce fibrate. However, the randomized controlled trials are needed. However, it can be used to reduce anti-inflammatory effects. So in our patient with the 15,000 triglycerides, we had started on insulin infusion, followed by which dietary recommendations were recommended to her. Initially, we had started on fenofibrate 160 mg, followed by which we had doubled the dose of fenofibrate, along with we added rosuvastatin on a serial basis, followed by which omega-3 fatty acids. We have planned for genetic testing and screening. When she was however discharged at request with the last triglyceride we had of value of 4030. So our final diagnosis will be a probable familial type 2 dyslipidemia with a young onset diabetes mellitus and a probable mechanical back pain.
Are there any questions? I think maybe that back pain was little misleading because your entire presentation was about maybe that part, I don't know. And can focus on one thing. Like if you want to tell about hypertriglyceridemia, just tell about that. Means if you confuse everybody with like if you want to tell only triglyceridemia, just tell only that one. Is insulin infusion used only in patients with pancreatitis or in asymptomatic people?
Asymptomatic people we don't want to use, ma'am. But if we are feeling that there is increased risk of pancreatitis, as there is a chance, we might need to use it. Any patient who had previously developed a pancreatitis who had a continuous high triglyceride, it's better that we use insulin infusion and reduce the triglyceride so that they don't occur at a pancreatitis.
Oh, your patient you used because you thought there was
a very high chance of
pancreatitis. So there are no randomized control trials to prove that insulin actually helps. These are only some case studies, right? Case studies only. So only the medication is what is in guidelines also. Insulin infusion is not in the guidelines.
The absolute value of triglyceride over which 100% have to start.
No, there is no absolute value.
And it's only for hypertriglyceridemia, not for any of the.
No, it's only for hypertriglyceridemia. We just started because there is increased chance of that.
Thanks.